I was asked to talk about palliative care for men with prostate cancer. I think it was an oversight. I hope it was an oversight. But when there was mention of the Cancer Agency this morning, palliative care seems to have dropped off. Palliative care is an integral part of the cancer trajectory from diagnosis through to death because, like it or not, a lot of people in New Zealand die from cancer. And a significant proportion of those people are men with prostate cancer. So I'm going to talk generally about palliative care and then a little bit more specifically about prostate cancer and then end up with just a quick overview of the psychosocial needs of all people with cancer. So here's the definition. The palliative care is an interesting specialty because it's redefined itself. It's had to redefine itself on a number of occasions over the 50 years. It's 50 years this month since Cicely Saunders opened the first of the modern hospices in Sydenham in London. And at that time it was known as terminal care. And of course that's not really a very good name. We're just going to get the terminal care doctor to come and see you. I don't know that it's much better with palliative care, actually, because the thing about palliative care is an awful lot of people think, oh, yeah, palliative care. But they don't actually know what we do. They think that we just sit at somebody's bedside, holding their hand, mopping their brow, filling them up with morphine. But the reality is palliative care is a very active form of treatment. If you think about the sort of people that we care for, they are people with complex illnesses, often more than one illness. They have organs which are often failing, kidneys that are not functioning particularly well, livers that might be failing, lungs that might be clogged up. And they're on average, when I see somebody, the average number of medications they're taking is 9. So that's quite complicated if you imagine the drug interactions and so forth that goes with that. But having said all of that, people coming to us expect us to improve the quality of their life. Now, quality of life is a kind of nebulous concept. If you each think about what it is that makes quality in your lives, you may come up with a whole string of different elements. And so if we got everybody to say one thing this afternoon, there might be some similarities, but there probably would be some differences. And the similarities, as I pointed out yesterday, quite often come down to two very basic things. It's not to do with whether you've got food in your tummy or clothes on your back or a roof over your head, although those things clearly make a difference. Two of the things, the top-rated things for improving quality of life are first, the presence of meaningful relationships. And the second is the ability to feel light-hearted. And very often, when people come, first of all, to a palliative care consult, there's not very much to feel light-hearted about. You know, they're entering a phase of their illness where they have to acknowledge that they're not going to be cured. Now, that is problematic because a lot of times, even though the doctors nowadays only rarely say with great gusto, oh, I've got it all. I think that people like to believe that they've been cured. And very often times they haven't actually been cured. They might have been put into remission and they might be living with a cancer, which then might rear its head. I met a lady just last week who was first diagnosed with her breast cancer 30 years ago. And it's recurred this year. I met 2 men with prostate cancer who had been symptom-free for a very long time, and the disease has recurred. Now that's not, we heard this morning all about the registry, and that's clearly a very important part of what's involved in cancer care, but the inevitable is that some people will die from cancer. So we're trying to look at the problems that those people are facing. Not only those people themselves, but as we heard again this morning, the family is significantly affected. The thing about families is that no 2 family members ever agree. And no 2 family members have the same emotion at the same time when somebody in that family is going through the last weeks or months of their life. Some people will be angry, some people will be sad, some people might be pleased. Not everybody is sad when a family member dies. But what we're talking about is life-threatening illness. And in order to move forward, we have to, most times, try to help people to understand that what they are facing is a life-threatening or a life-limiting illness. And that can be difficult for men who have had treatment a long time ago and have been living with their cancer for a long time to suddenly realize that actually the thing has escaped control. So the way that we do that is to try to prevent and relieve suffering. Now, yesterday we spoke about suffering, and I talked about the work of a physician called Eric Cassell, who created this idea, which I find very attractive myself, that we're all integrated people. We all have a number of different facets. We have a physical part, a psychological part, a social part, a spiritual part, a sexual part, a political part, a financial part. And all of those things, when we're well, they work in unison, in harmony. What happens with suffering is that one or other of those bits begins to peel away. And so you begin to literally disintegrate. And the role of the palliative care team is to try to identify what those elements are and to try to remedy them. Now, some of those things you can't remedy. And sometimes we can make assumptions about suffering. Somebody may come to see me in the clinic with excruciating pain because of bone disease or fractures or whatever. And it's easy to make the assumption that that person is suffering because of their pain. But until we ask them, we don't know what their suffering might be. I imagine that when I'm dying, part of my suffering will be the fact that I won't be able to hold the people who I love anymore. It might be that I won't see my grandchildren reach their full potential. Now, there's nothing you or anybody can do about that. You're not going to relieve that suffering. And so some sufferings have got to be borne. It's part of the human condition. It's part of the price we pay for having loved. But I think there are elements of suffering which can be alleviated and are alleviated. So what we need to do is identify those elements early and assess people impeccably, and that really does mean impeccable. So we have to look at every facet of their life, the way they live it, what their hopes and fears are, and what the disease is doing to them. Commonly, people worry about pain, and the idea you was pointing out yesterday that a lot of the legislation that relates to assisted dying talks about pain. Pain isn't, for very many people, the worst symptom. Fatigue is the worst symptom. Breathlessness is another bad symptom. There are things which... The thing about palliative care is, we all think we know what pain is, we all think we know what breathlessness is. If I asked you to run up and down the stairs, most of you probably would get breathless eventually. But what we're talking about is symptoms in a much bigger degree. I might think, well, I had friends around for dinner last night and they wouldn't leave, and so I'm a bit tired today. The tiredness that people with cancer experience is like no other. It's just an overwhelming feeling. So we need to address those problems. We need to address the psychosocial, and we need to address the spiritual. So what we do is we try to provide a relief from those symptoms, and we do that quite well. I think we're quite good at managing physical symptoms. You can. There are some symptoms like that fatigue that I was talking about that you can't give somebody a pill for. But certainly pain management nowadays has come on in leaps and bounds, and physical pain can be alleviated. Not 100% always, but it can certainly be changed. And part of the thing about having chronic or unremitting pain, cancer pain, is that men who have it don't want to live like that. quite often, maybe every week, I would have somebody say to me, Doc, you must have something. Why can't you just end it all now? And those people are genuine in that statement. What they're saying, though, they don't necessarily want to be dead. What they don't want to do is to live like they're living now. And so what we aim to do is to change the way that they're experiencing those symptoms. And almost always those requests for an end to their life fade away. I have had one man in my almost 30 years in palliative medicine who's persisted in his request for euthanasia. He was a member of the Voluntary Euthanasia Society. And I would say to him every morning, well, if it could be today, would it be today? And he'd say, no, I'm fine today, but it might be tomorrow. And he wanted to hold on to that belief that perhaps something could have been done. Another important thing about palliative care is that it affirms life and regards dying as normal. Now, the challenge there is that if you believe what you see on the television and read in the newspapers or online, you're almost led to believe that we're becoming immortal. Doctors talk about breakthroughs in this, that, and the next thing all of the time. But the reality is it's normal to die. You might have noticed. Everybody dies. And yet we don't, as a society, talk about it. The fact that we can have a whole discussion this morning about a cancer agency or a discussion about a registry without a single mention of the word death. It's a reality. As David Clark said, 1/3 of us are going to die of cancer. And so a number of men with prostate cancer will die from it. Also, an equally large number will die with it. So that's, you never know which group you're going to be in. But affirming life is important. And very often by the time people come to see us, they're feeling worthless and hopeless and demoralized. And often they feel that life isn't worth living because they've been through a medical process. They've had operations, they've had radiation, they've had chemotherapy, hormone therapy, whatever. All of those things have got side effects. All of those kind of beat you down, and the cancer's growing as well. So it's not surprising for people to feel, what's the point? One of the best things that hospices do is that they run a biography service. I know that might sound a bit strange, but often people get to the end of their life and think, was that it? What was that for? That's part of that spiritual questioning. But if you can sit down, as we do with every person who comes, and hear their story and value them for who they are, I have yet to meet a person in my career in palliative medicine whose life wasn't worth living. Yes, I've met very sick people. Yes, I've met people who've been horribly disabled. Yes, I've met people who were very nearly dead. But all of those people have a spark of life. And our job is to try to fan those flames. And it's the same whether they're a young man with prostate cancer or an old man with colorectal cancer. It doesn't matter. We can always try to find something which makes that life worth living. We intend neither to hasten nor postpone death. And that's a really important message, because I've had colleagues in the medical profession who think that what hospices do is they float people out in a purple haze of morphine. They think that that's we just fill people up and off they go. We don't do that. We never intentionally hasten somebody's death. In fact, there is a couple of studies now which have demonstrated that if you have good palliative care, you can actually extend somebody's life. You free them up from pain and they live a little bit longer. Now, some people might not necessarily think that's a good thing, but most people do. We integrate psychological and spiritual aspects of patient care, which are often missing in hospitals. If I go and look in a health record at Auckland Hospital today, I doubt very much whether I'd find out very much about somebody's spiritual beliefs or their spiritual framework. And by that I mean what makes their life worth living, what gives their life meaning. For some people that's to do with their faith, but for the majority of New Zealanders it's got nothing to do with faith. But We all have something which gives our life a structure. And when you're facing death, you begin to question that. You begin to think, well, what was the point of that? Or you might think, well, why is this happening to me now? What did I do wrong? Or what's the future going to hold? Or how are my family going to cope? All of those things are things that men think about. Andrew Little spoke about it this morning. He wasn't necessarily concerned with himself. He was concerned about his family, and he's not alone. The majority of men will do that. And we offer a support system to help patients live. People often say to me, oh gosh, isn't it sad working with people who are dying? Actually, I don't. I work with people who are living. All the people that I care for are alive. Almost all of them die, but then who doesn't? And we offer a support system to help the family cope. As I said before, families never agree about anything, just about. And we have to be able to listen to the families and help them to come to some common understanding about the goals of care. We need to help them with their own grief, with their own anger, with their own distress. And we help them through bereavement as well. New Zealand hasn't got a particularly good track record of helping people through bereavement. We don't have a universal bereavement service. A lot of hospices, all hospices will provide bereavement services, but not everybody gets referred to a hospice. So I think we need to find ways of helping people to adjust to bereavement, which it's not a pathological condition, almost always. It's not a medical diagnosis, bereavement. It can become one if it's complex, but most people need to learn how to deal with loss. And we do this by using a team approach. No one person can do this on their own. You might spend time, if you come to the Hibiscus Hospice, with me or with a particular nurse, but we don't ever do it on our own because each of us has different skills. So we aim to enhance quality of life and, as I said, positively influence the course of the illness. And now, those things aren't generally understood, and we haven't been good as a discipline of getting those things out into the public arena. You don't read about good dying in the Dominion Post or the Sunday Star Times. You read about bad dying. But most times we do enhance quality of life and we do help people to live well. And the other thing which is important, which a lot of medical people don't appreciate, is that palliative care can be applicable in conjunction with a whole bunch of other treatments. So there are times when I share the care of men with prostate cancer with their urologist or their oncologist or their radiation therapist. We aren't the rubbish bin option. It used to be, 50 years ago, terminal care, the last 2 or 3 weeks of somebody's life, everybody did what they could and then handed over to us. There's nothing more we can do. That was a common thing that was said to people. The doctor said there was nothing more they could do. That's nonsense. There's always something that you can do. I never say to people there's nothing more we can do. We never abandon people. There is always something we can do to help. So where is it best delivered? Well, for most people, it's best delivered in their home. And if you ask 100 New Zealanders where they'd like to receive their palliative care, I bet you almost 100 of them would say at home, wherever that might be. It should be available in all hospitals. It is in varying degrees. It should be available in residential care. Well, the government have just given quite a lot of money to hospices to partner with residential care to make sure that people in residential care get good palliative care. And for a very small proportion, they'll receive their palliative care in a hospice. I think it's only 4 or 5% of New Zealanders will die in a hospice. Most of you may not be aware that most people who come into a hospice go home feeling better. More than half of the people who come into a hospice will go home feeling better. Yes, a proportion of them will die, but more than half will go out. So who's best placed to deliver palliative care? Well, it's generalists, it's family doctors. Family doctors are the best people to deliver palliative care because they know how you, as an individual, and a man in your family, they know how you respond to illness. They've been looking after you for a while. They'll know a little bit about your family. Occasionally, things get complicated, and we need to call in specialists. So generalist palliative care is GP teams, Māori health providers, allied health, residential care staff, and all the staff in a hospital. They should all be able to deliver palliative care. The challenge is that in New Zealand universities, it's the most miserable failure of my academic life, is that I've failed to impress on any university, and I've worked at in Otago and Auckland, the importance of palliative care. Every doctor who graduates from a university in New Zealand will probably look after about 40 people who are dying in their first year, on average. Some more, a few less. How long do you think we train them for in palliative care in a 6-week program? It's less than a week. It's pathetic. It's because we aren't a sexy specialty. You know, we're not like cardiology with lots of machines that go bing, and we don't have private practices, and we don't have the kind of big cohorts. When I was working at Royal North Shore Hospital in Sydney, there were 17 cardiologists in that hospital, and there was me as a palliative medicine specialist. Now, the cardiologists aren't actually going to cure very many of their patients. They're probably all going to die. So how come there are 17 cardiologists and 1 palliative care doctor? I think we've got it all a little bit topsy-turvy. Nevertheless, we do try to train the students so that they know at least how to listen to somebody who might be facing the end of life, and keep on chipping away at trying to get the schools to increase the amount of teaching that we're allowed to do. The average GP, the causes of death in a year, so that's how many people on average a GP will look after. So 5 of them, a quarter, will be dying with cancer. So men with prostate cancer almost certainly will experience symptoms, and probably the most worrying symptom, the thing that troubles men most, is to do with pain, and they get pain because of pain in their bones. But they also have some urological difficulties as well. The thing about early prostate cancer, of course, is that it often has no symptoms. So bone pain is common, and the thing about getting involved with the palliative care team is that they will work with you to work out what the best thing for you to do is. There may be a whole range of medicines, because not all bone pain can be magically removed with one pill, but non-steroidal anti-inflammatory drugs might be used, although they're being used less. Steroids might be used to reduce the inflammation in the bones. Fatigue, as I've said, is very common, because a lot of the treatments that men receive cause fatigue. And if you haven't been down to see the Pink and Steel cancer rehabilitation thing, which with Look Good, Feel Better downstairs, go and have a look, because if exercise were a chemotherapy drug, it would be trumpeted as the best drug that had ever been invented. Because we know that if you exercise properly, pain is reduced, fatigue is reduced, sense of well-being is increased, and there is now increasing evidence that longevity is increased. The likelihood of recurrence from some cancers appears to be reduced by appropriate exercise. Things like cancer cachexia. I've got a PhD student who's just submitting, who's done a study on the wasting that happens with some cancers, with a multi-targeted approach which includes exercise. There is gathering evidence to say that those things are hugely beneficial for slowing down that wasting process. So I think in the next 10 years we'll see an explosion in our understanding of why exercise is a good thing. And so a lot of hospice programs might well recommend going through an exercise program. So I just want to finish talking about the psychosocial needs, because the physical needs in many ways are kind of self-evident. The psychosocial needs maybe tend to get overlooked, and we've heard about the psychosocial needs from our nursing colleagues this morning. Men need to have a sense of security. They need to have a sense of security in all sorts of things. They need to feel secure with their urinary symptoms, but they need to feel secure in themselves. They need to feel that they're safe. They need to feel a sense of belonging. Now, a lot of people we all, I think, need to feel needed. The trouble with having prostate cancer and some of the treatments that are provided is that men often don't feel like men anymore. And so they feel that they don't belong, they don't have a particular role in the same sort of way. And they might feel like they're a burden because they can't do the things that they used to be able to do. There is a reason that we're called human beings. It's because our being is so important, our doing less so. We do value what people do. You've only got to look at the news and see the doings of the America's Cup, or the doings of the All Blacks, or the doings of the New Zealand Warriors. You know, those doing kind of things are applauded. But actually, it's the being part, particularly this part of life, which is important. And men need to have a sense of being loved. Now, some men that I've looked after have been quite difficult to love because they're grumpy and smelly and don't want to wash and swear a lot. But there's a reason for all those things, and it's our job to try and find out what that reason is. And people need to be held. They need to have touch. And those of you who were here yesterday will have heard the importance of intimacy. The difficulty for men is that they don't necessarily have the same kind of physical function that they used to have, but they still need to have affection. They still need human skin-to-skin contact, which is the most powerful thing that humans do with each other. People need to be accepted, regardless of mood, sociability, or appearance. It was lovely last Thursday. We've got a man who actually has prostate cancer, and the nurse went in to see him with me, and I was talking about what he was planning for the day, and the nurse said, "Oh, he's going to have a shave and a shower." And this guy said, "No, he's not." And the nurse said, "Oh, you haven't had a shower for days." And he said, "Well, I'm not going to either." We need to fit into their routine, not them into our routine. I think that's part of the difficulty about hospitals, is that there's a routine so they can work efficiently. But if we're providing care for men with prostate cancer, we need to find out what they want and accept them for who they are. They might be grumpy, they might be smelly, they might be dirty, but they're still a human being. And so we need to get past our immediate response. Men need to have a sense of understanding. They need to understand the symptoms, they need to understand what's happening to them, and they need to understand what's going to happen to them. I've looked after tens of thousands of people who've died, and so I've got some idea of what that process is going to be like. It's not a secret. I'm not going to keep it secret. If men want to know what's going to happen, I'll tell them. Not everybody wants to know, but those that do want to know have a right to know, and the family has a right to know. We have a booklet that we give people. This is what may happen with your loved one. And when we were first writing it, there were people who did, "Ooh, no, you can't tell them that." Of course you can. People are frightened. What are they frightened of? They're frightened of uncertainty. We can give them a degree of certainty right until the moment of death. We can't necessarily be certain about what comes after that, because nobody's told us. But we can be certain about the process of dying. People need to have a sense of self-esteem. The men need to be involved in decision-making, not having people make decisions for them. You know, there used to be a great program on the BBC radio called Does He Take Sugar? And quite often I'm reminded of that in the hospice when, somebody might ask the wife, "Oh, does he take sugar?" As if he's invisible or deaf or mute or whatever. People need to have a sense of spirituality. They need to be able to explore their spirituality. You might not feel that's important when you're well now, sitting here in this lecture room. But as you get towards the end of your life, however long away that might be, you will begin to ask questions about meaning and purpose. And people need to explore that. I don't have the answers. Sorry. But I can listen and help you work out the answers for yourself. And people need to have a sense of hope. Most people think, "Oh, I'm going to the hospice, that's all a bit hopeless." Actually, that's wrong. Hope is something which helps us to keep alive, helps us to wake up in the morning and helps us to get out of bed. When I talk to medical students, I ask them about their hopes. Their hopes are to do with paying off their student loan or qualifying or getting married or having a house. The people that I'm working with have hopes. I try to help them, if they're an inpatient, I try to help them to identify what they might be hoping for today. Thank you very much. What do you hope for today? What do I hope for today? And it's probably worth thinking. I mean, you might all hope that you're going to win lotto or that you can get home without being rained on or all sorts of funny things. But for men who are near the end of their life, they will have hopes too. We need to help them to achieve those realistic hopes and to help them to get rid of some of the unrealistic hopes. Yes, of course, everybody will hope that some miracle cure will happen. Yes, miracles do happen. People do get discharged from the hospice program. Diagnoses are wrong sometimes. Not, sadly, very often. But we do have the ability to hope for something which will improve the quality of our lives. So if you are a man involved in a hospice program or thinking about being involved in a hospice program, or you're working with people who might be involved in a hospice program, make sure that you just keep asking the palliative care team. They won't give up on you. They won't abandon you. They'll help you to live your life to the best of your ability. Thanks very much.